Dear Professor, now we will start AstraZeneca Symposium. Professor Ala Andil.
Good afternoon, everybody. We are continuing our scientific session, and now we are starting AstraZeneca Symposium. We have two very eminent speakers today, and we would explore hormonal treatment in hormonal-dependent breast cancer and how we can get much more benefit in treatment of those ladies without going to chemotherapy. I have the honor to be a chairperson of this session. The co-chairperson is very dear and very eminent Professor Dr. Fuad Abu Talib, Head of Oncology, Clinical Oncology Unit in the Gazig University, Professor Dr. Ahmad Hamada, Professor of Clinical Oncology, Qasr Al Aini School of Medicine, Cairo University. And again, I have the honor to introduce my dear professor and very eminent and known for all of us, Professor Dr. Ala Andil, Professor of Clinical Oncology, Alexandria School of Medicine, Alexandria University. His presentation will be directed to Faslodex in the management of her hormonal responsive metastatic breast cancer patient. Please, Dr. Ala.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Professor Heba, for this very nice introduction. First, I'd like to thank the organizing committee and the personnel of AstraZeneca for giving me this opportunity. As mentioned, this is an introduction to the role of not really a very new agent or a new team player in the management with hormonal treatment in the patients with metastatic breast cancer, fulvestrant, or commercially known as Faslodex. With a problem of the magnitude of breast cancer, having at least more than 1,300,000 cases a year, with half of them unfortunately go into cancer-related death, most common cancer in women, with a different outcome among different stage categories, being excellent at stage 1 and worst at stage 4. And with the new data that we have from the molecular profiling, knowing that we have at least four major types of breast cancer, these are two genuine data sets showing us that we have two hormone-responsive subtypes, luminal A and luminal B, with definitely much favorable outcome as compared to the two other subtypes, the known HER2 positive and the triple negative. And you can see that these are genuine data sets, being patients treated only with surgery with no adjuvant treatment, and you can see the clear distinct outcome between the subtypes just by them belonging to one subtype. From any epidemiological data set, we know that at least about 60 to 70% of breast cancer patients are hormone responsive, at least luminal A and or B, 25 to 30% HER2 positive, and about 10 to 15% who are triple negative disease. Through the years and the last decades, we have experienced at least 30% improvement in the outcome of breast cancer patients, and about half of which is due to screening, and the other half is due to adjuvant therapy. And when I say adjuvant therapy, I'm talking about hormonal, chemo, and targeted therapy. We have learned from the breast trials group data that the benefit of tamoxifen given for 5 years for patients with breast cancer patients did make a difference in terms of recurrence, as you can see, and the benefit is maintained up to 15 years, and in terms also of breast cancer mortality, and again, significant difference up to 15 years. So we learned that. However, the current state of affairs applying hormonal therapy to breast cancer patients tell us more than one thing. Still, recurrence rate have decreased with adjuvant aromatase inhibitors and anti-estrogens for sure, but they had minimal impact on overall survival. Still, in premenopausal women, the role of ovarian suppression remains unclear with plenty of question marks. And again, the gains we have already obtained in the setting of ER-positive metastatic disease have occurred, but with no trials that have resulted in substantial improvement in survival. To emphasize my point, from two huge data sets like the ATAC trial and the big 198, where anastrozole was used in the ATAC trial and letrozole were used in the big one, we have an improvement, again, in terms of decreasing recurrence and disease-free survival, but that did not translate into improvement in overall survival. We might have some explanation for that. Number one is to elaborate on the heterogeneity of the ER-positive breast cancer. They are not all the same. In addition to the problem of late recurrences for those patients who stop hormone treatment at some time point. In addition to that, the complex issue of resistance to standard endocrine therapy. And the question sometimes is not to who are the patients that would benefit, rather than sometimes the question is who are the patients that should not be receiving such a type of treatment, whether hormonal, chemo, or targeted therapy, which is an extremely important in tailoring treatment for every single patient in modern medicine. Again, the heterogeneity is mainly due to the degree of ER expression, because not all hormone-responsive tumors are the same. In addition to the genetic profile and the intrinsic subtype, some patients do express hormone sensitivity, but they are HER2 positive. They are completely different from patients who express hormone responsiveness and are HER2 negative. And the degree of proliferation among these tumor subtypes being hormone responsive, more importantly, the activation of other growth factor pathways known to us, like the AKT, PI3K, and the mTOR pathways. As an example, to elaborate in that, in a very elegant study, the Bolero-2, which we are proud to participate in Alexandria, has examined that, which is adding one aromatase inhibitor element in addition to one other new element, which was a targeted therapy in a form of tablet form, a PO form, an mTOR inhibitor, the known everolimus. And this is more than 700 patients, postmenopausal, hormone-responsive, HER2-negative, advanced breast cancer patients who have been refractory to non-steroidal aromatase inhibitor, letrozole or anastrozole. These are the design of the study, simply either receiving exemestane in the lower arm or exemestane plus everolimus at a dose of 10 milligram per day with a primary endpoint of progression-free survival. Very simple and elegant design. And the data speaks for itself. You can see a very clear benefit for those patients receiving the combination in terms of progression-free survival with a hazard ratio of 0.36, an improvement of almost thank you. Shukran. Okay. A very significant improvement. As you can see, the difference between both curves by adding an M2 TOR inhibitor to the regular exemestane, and the benefit was maintained on all subgroup analysis for those patients. This is just one example. Our talk today is about not really a very new member in the family. However, I believe it's a very important member of the family in the team of hormonal therapies, which is fulvestrant or Faslodex. This drug is approved already in the use of postmenopausal breast cancer patients, either advanced or metastatic. It's an estrogen receptor antagonist. It's a down regulator rather than a modulator. We know that the tamoxifen and raloxifene, for instance, belong to the SERM groups, which is modulators. This is a down regulator. This is an extremely important difference in the way it acts on the hormonal level. The selective ER down regulator fulvestrant is a pure anti-estrogen that, on binding to the ER estrogen receptor, induces a conformational change that disrupts ER transcriptional activity and accelerates ER degradation. These features are very unique to fulvestrant, and there it comes its uniqueness from that. It does induce a rapid loss of ER protein, and data already has shown that this downregulation is dose dependent, as we will see through the slides. As opposed to fulvestrant or the downregulator, the SERMs or the modulators, the other anti-estrogens such as tamoxifen or raloxifene, retain some estrogenic activity and do not reduce ER levels. This is not true for fulvestrant. On the other hand, we all know that the aromatase inhibitor effect, namely the steroidal and the non-steroidal, it goes by reducing the levels of circulating estrogen in postmenopausal women by inhibiting the peripheral conversion of androgens to estradiol. So what's behind the story that we reached upon now, which is the 500 milligrams of fulvestrant? There are several preclinical data showing us the effectiveness of fulvestrant in breast cancer patients with a dose dependence that has been very clear through the very early studies. And also, that's shown from one of the studies a very simple design of taking a biopsy from 200 patients, randomize them to 5 different groups, adding fulvestrant at 3 dose level, 50, 125, and 250 milligrams, and one arm to add tamoxifen at 20 milligrams, and the last one is placebo, and then to examine the surgical specimens of those patients thereafter. And you can see a very clear benefit for benefit, dose dependence. As you can see, a very gradient dose level between the 50, the 125, and the 250, and these are definitely 2 significant effects as opposed to tamoxifen alone, and for sure placebo does not make a difference in there, and the difference was statistically significant if you measure it by the down regulation of the estrogen receptor. The same was true, a very steep gradient with the PR itself, and more importantly, it was still consistent with the Ki-67 labeling index, and this is a very well-known proliferative marker. You can see the gradient between the 50, 125, and 250 milligrams. This speaks for itself. More and above, in terms of time to progression, we have data from 2 phase 3 trials examining anastrozole at 2 dose levels, 125 and 250 milligrams, compared to the standard aromatase inhibitor anastrozole, and the data collectively is telling us that fulvestrant, even at a dose of 250 milligrams, is at least as effective as anastrozole in the second-line treatment of patients with advanced or metastatic breast cancer. This is very important. To sum up, we have strong biological rationale to evaluate a dose higher than 250 milligrams per month. There are 3 main trials that I will elaborate on one in a little bit more details, and my dear Professor Dr. Nabholz will elaborate in his talk about the 2 other trials. We'll go through them very quickly. The newest trial, this is a neoadjuvant pre-surgical endocrine therapy of women for women with endocrine-sensitive tumors. This is the study design. Patients with non-metastatic hormone-responsive disease having T more than T2 or above. We have baseline tumor measurements by ultrasound with core biopsies, and this is an open label randomized 1-to-1, where patients were randomized between fulvestrant 500 milligrams or 250 milligrams. Again, tumor measurements by ultrasound and core biopsies were done at 4 weeks and at 16 weeks, thereafter going to surgery and to be followed up thereafter. To sum up, that was the first study to compare the biological and clinical activity of 500 and 250 milligrams, and the data tells us on clinical grounds at week 4, there is a significant reduced mean Ki-67 labeling index in the 500 milligrams as compared to the 250, with a very significant p-value. There is also reduced ERP expression significantly more than the 250, and again reduced ER and PR expression significantly more than 250 milligrams. The benefit was still maintained at week 16. Reductions were also observed for fulvestrant 500 milligrams versus 250, but were not significant at that time point, which is 16 weeks. The first trial, the second trial, which is comparing fulvestrant 500 milligrams with anastrozole. This is a phase 2 trial with 1-to-1 randomization, open label, hormone responsive positive tumor with postmenopausal patients with advanced breast cancer, 200 patients, and the primary endpoint was clinical benefit rate. The time to progression is already shown on that slide, and again Dr. Nabholz will go through that in more details, and the sum up for that is that 500 milligrams showed similar efficacy, or at least similar efficacy to anastrozole in terms of clinical benefit rate and overall response rate, and it was associated with a significant benefit in time to progression compared with anastrozole. Last but not least is the confirmed trial, is the comparison of Faslodex in recurrent or metastatic breast cancer. This is the background I already talked about in my previous slides. This is fulvestrant 500 milligrams compared to 250, and this now comparison in a phase 3 randomized trial, more than 350 in every patient, with a primary endpoint of progression-free survival and numerous secondary endpoints. As you can see, treatment was given with regular follow-up till progression in both arms, and the sum up at 50% maturity reduced 500 milligrams fulvestrant reduced the risk of death by 16% compared to 250, and the median overall survival for 500 milligrams versus 250 milligram was 25 versus 22.8 months respectively. There was a significant improvement in the duration of clinical benefit, and safety-wise or toxicity-wise, there was no significant difference between both arms, apart from some gastrointestinal differences, and these are the conclusions of the 500. One last talk I'd like to elaborate on before giving the floor, which is again the combination of two lines of hormonal therapy. This is a very interesting SMART trial that was presented at the San Antonio Breast Cancer Symposium the year before the last one. And here they are combining anastrozole with fulvestrant in an randomized fashion. This is the SWOG S0226 trial, and this is the rationale of the trial. There are plenty of in vitro and in vivo data to support the combination, and these are the eligibility criteria for the patients to be included in this. Postmenopausal women with metastatic breast cancer should be hormone responsive, either by being ER and or PR positive, with no prior chemotherapy, hormonal therapy, or immunotherapy for the metastatic setting. Prior adjuvant tamoxifen is allowed, and that was one of the stratification factors, as you will see from the results. They could have prior adjuvant aromatase inhibitor allowed if they completed that at least 12 months before randomization. And again, neoadjuvant or adjuvant chemotherapy completed more than 12 months, 1 year at least, before inclusion in the trial. This is the schema of the trial. Simple, again, design. Anastrozole was given in the usual 1 milligram daily dose until progression, and the second arm, anastrozole, added to fulvestrant in this manner, a loading dose of 500 milligrams, followed by 250, day 14, day 28, and then 250 every 28 days thereafter. Okay? Again, treatment till progression, and the study was 90% power to detect an increase in median progression-free survival from 10 to 13 months. Very comparable two subgroups with a median age of about 65 years, and prior adjuvant tamoxifen were applied in about 40% of the patients, with prior adjuvant chemo in about 30% of the patients. Nearly half of the patients had measurable disease in both subgroups. Very interesting actually to understand the data of this trial is that crossover was allowed, and the patients in the anastrozole only arm were strongly encouraged to cross over to fulvestrant after progression. And by February 2011, patients on either arm, either the combination or the single anastrozole, were allowed to cross over to the monthly 500 milligram anastrozole fulvestrant, which is the higher dose of fulvestrant. And 41% of the patients on the anastrozole only arm did cross over to fulvestrant combination arm after progression. This is quite interesting. You can see actually that there is a significant improvement in terms of progression-free survival for the combination, adding fulvestrant to anastrozole. This is excellent. Actually, that goes by the principle that we were talking about from the preclinical data. However, when you stratify that according to the prior tamoxifen use, for those patients who had prior adjuvant tamoxifen, the difference was not really significant, with a no significant p-value 0.37. But for those patients who had prior tamoxifen or no prior adjuvant tamoxifen, the significance was very high, 0.055. And the median progression-free survival was quite evident, and you can see the difference between two curves. The same applies more or less to overall survival. As you can see, the combination patients did better than the single anastrozole. Again, the benefit was not seen for those patients receiving prior adjuvant tamoxifen, and was seen in a significant fashion in the patients who did not receive prior adjuvant tamoxifen, and the benefit was clear and there consistently in all subgroup analysis related to age, HER2 status, hormonal status, metastasis being visceral or non-visceral, or other subgroup analysis. The combination did better with an overall hazard ratio of 0.8. Toxicity-wise, observed some patients, few patients with grade 4 and 5. You can see that 3 patients on combination had grade 5 toxicities, and 2 other patients on combination had grade 4 toxicities, but still, even on the single anastrozole arm, there was 4 patients on anastrozole group that had grade 4 toxicities. Going into grade 3 toxicities, more often, there was 13% in the combination arm and 11% in the anastrozole arm with no significant difference. So it's more or less quite safe to apply that. And the conclusion is that the combination of anastrozole and fulvestrant in those patients did improve progression-free survival and overall survival, and the toxicity of the combination treatment is comparable to single-agent treatment, though grade 5 toxicity was seen only with the combination in 3 patients. So to sum up, we need still larger number of patients to be included in trials with longer follow-ups. More and above, we need newer hormonal agents to be applied with more targeted agents to be added to these hormonal therapy treatments. We might be able to add 1 or more targeted agents in this setting, and to combine hormonal agents. This is very appealing and might be tried more and above, more and more. And we need to understand better the issue of hormone resistance. And thank you so much.
Thank you, Professor Ala, for your elegant presentation as usual. And we move to our next speaker, Professor Jean-Marc Nablus, Chairman of Department of Medicine, Jean Perrin Comprehensive Cancer Center, France. He will give us a talk about management of metastatic breast cancer, role of hormonotherapy and Faslodex.